Well, good morning or good afternoon, everyone. This is Joy Burkhardt, and I'm the Executive Director of 2020 Mom. We're so pleased to have all of you with us today. We see about 17 of you so far on the live webcast of today's Innovation Award program, and we know that many of you are going to be listening retrospectively to the recording, so welcome to all of you as well. I'm delighted to have three others with me on the line today. You don't see her face on the Innovation Award slide that's up on my screen right now, but want to give a quick hello and shout out to Christina Delaney, who is our project manager for the Innovation Award programs. Hello, Christina.
Hi, everybody. Glad to be here. Thank you for joining.
Thank you, Christina. And Christina is going to help moderate our session questions today. I also have with us Brooke Dorsch. We'll hear about Brooke in just a moment, and also Dr. Latondris. Welcome to both of you. Before we get into the content of today's webinar, I wanted to say thank you to our funder of the Innovation Awards program. This is the third year of the program, and we couldn't do it without the financial support of the Zoma Foundation. So thank you so much to Rebecca and the Zoma team in Colorado for making this program possible. And congratulations to both of you, Brooke and Dr. Latondris, for receiving the Innovation Award in Advocacy as our honorable mention program honoree. So congratulations, and I'm going to go ahead and introduce you now, and we'll jump right into our program. I'm going to start with Brooke and share that Brooke is the maternal mental health specialist at the Utah Department of Public Health. She's also the leader, one of the many leaders of the Postpartum Support International chapter in Utah. She does work at the state level around training in maternal mental health, providing resources and conducting quality improvement for providers and community members, as well as working with women and creating public health campaigns. She has earned her Bachelor's of Science degree in Public Health from BYU and received a Master's in Social Justice and Human Rights from Arizona State University. She has lots of great experience and is really doing some fun things on a personal level, and she loves to hike and loves to look at dog videos on YouTube. How fun is that, Brooke? Thanks for sharing that fun point of personal interest too. It's good to know that we all have a human side, not just a professional side. And next I want to introduce Dr. Latondris. Dr. Latondris is an associate professor and assistant dean for masters at the Department of DNP programs at the University of Utah College of Nursing. She engages in interdisciplinary research on perinatal mental health, which we're so excited about that work that you do. She uses PI on two funded research projects. So she is the PI, a principal investigator on two funded research projects on the use of telehealth to deliver interventions. And we'll get to hear about that work from her here shortly. Welcome to both of you, and again, congratulations on your award.
Thank you so much. Delighted to be here.
Great. Well, let's jump right in. So I'm going to turn it over to you, Brooke, to just walk us through a little bit about your community, if you would. Talk to us a little bit about Utah and what makes Utah unique. And if you also want to talk a little bit about the Department of Health. I called it the Department of Public Health and should have said Department of Health earlier. Tell us a little bit about the Department of Health and when the Department of Health became interested in maternal mental health.
Yeah, thank you so much, Joy. And thank you so much for awarding us the honorable mention for policy and advocacy. We were nominated by a mom here in our state, and it means so much that that people with lived experience really are feeling honored and feel like they can tell their story and they are being part of a greater national community, which is amazing. So as you see on the slides, those are pictures of our beautiful state. That's all from the rural area, southern Utah, all the way through the more urban area, the Wasatch Front. And because this award is about policy and advocacy and translating that into actual programs, we really wanted to give kind of a background, as you asked, the community and who is involved in this. So if you want to go to the next slide, I'm actually going to highlight all of the big players here with general maternal mental health in Utah. So our community spans everywhere from providers to legislator and the community members. And the way that we're able to do that here in Utah, it's such a unique state because the majority of our population lives within a pretty small radius of our state, and then the rest is rural or frontier, considered rural or frontier. And so a lot of our main players serve different populations. So I'm going to go into the timeline on the next slide later, but just for now, we kind of have this idea within our community of this Utah touch points for mom's mental health. And that was kind of the foundation for everything that's happened here within the last 5 or so years. But we have this idea that moms throughout her pregnancy and then up to 1 year postpartum see a variety of different types of people, everywhere from a lactation consultant to, even a worker at Target or a lot of, their OBGYN or midwife, possibly technology and internet, et cetera. So that's kind of the foundation for how we've been able to form what we have here in Utah. So starting with the many players, PSI Utah. So that actually, it turned into PSI Utah back in 2017, but way before then was the Utah Maternal Mental Health Collaborative. And that was founded by Amy Rose White here in the state, and she said she realized that there was a gap with maternal mental health here and said, hey, we need to get all of the big players together and start talking about how we can address these gaps. So in 2017, the Utah Maternal Mental Health Collaborative turned into PSI Utah, and from there was born a group that focuses just on policy. So there's a PSI Utah policy group. And that group is made up of all the rest of the people that are listed here, which includes the Utah Department of Health, and that was my boss and her boss within the maternal and infant health program. So the Title V program for the state got involved and said, hey, mental health is a huge part of maternal and infant health. Next on the bullet point are advocacy groups. So the YWCA, they hired somebody to focus just on policy and advocacy, and she said, I can't focus on women's policy and advocacy without thinking about mental health. And so she joined in. Her name is Erin Jemison, and has been an integral part of creating policy and advocacy. And we're sad she couldn't be here today because she really has a lot of the answers of how we've been able to make that happen. For advocacy groups, we also have an advocacy group called the Emily Effect, which many of you on the phone may have heard of, and that was started by surviving family members of a woman who died from maternal mental health here in the state. And they've been a huge part of that. And then we have Voices of Utah Children, and they focus on the equity for children here in Utah. Next bullet point, we also have the Utah Women and Newborns Quality Collaborative, which is the quality improvement group here at the Department of Health. And there is a maternal mental health subcommittee that started just last year. And Dr. Latondras, who's here presenting with me today, actually chairs that committee. But they have been part of creating universal statewide screening protocols that we're going to be piloting and implementing. Other players that we have at the table include the University of Utah, which has the Telemental Health Project we'll be highlighting today. They also have an incredible unit that does psychotherapy and And then they also have a group that focuses on substance use within the perinatal period. And then lastly, we have Intermountain Healthcare and other major hospital systems. So all these different people, there's a champion at Intermountain Healthcare, which is one of the largest, if not the largest hospital system here in Utah. Her name is Jean Millar, and she is also, through personal experience and through reports back from their clients and patients, seeing that maternal mental health is really the foundation of anything that they want to do with, again, women and children. So as you see, our touch points have kind of created this really holistic approach to maternal mental health here, and people from each one of these groups sit on our committees. There's one other group that I left off of these bullet points, and that is the community. So people with lived experience, families of survivors, they also sit on all of our committees that we have, which are two big ones here in the state, PSI Utah and the Quality Improvement Collaborative. And they have provided a voice of both advocacy and their concerns on things that they felt were missed in their own experience, and have been a huge part of what we do here. So that kind of makes up our community, which sounds like everyone, and that's, I think, what has made us so successful. So if you want to go to the next slide.
Great. I'm going to just pause and ask a couple questions. I also want to remind folks that you have the opportunity to ask questions as well. You can use the question feature in the GoToWebinar control panel. It's that long rectangular box, usually shows up on the right-hand side of your screen, and you just open up that gray line that says questions and type in your questions there. We will pause a couple times for questions and make sure you have a chance to ask either of our two presenters anything you'd like to. So I see a couple of hellos as I open up the question box right now. So hello to all of you. We're glad that you're with us. Great. So just one question and comment. I also really like to point out that this work, the advocacy work, and really any state who's been successful at passing legislation from a grassroots perspective with multiple partners it's a long time in coming, isn't it, Brooke? That it's not that you just simply can put pen to paper and then suddenly you have a bill. Although I do think now more than ever, because of the interest in maternal mental health, there is possibility for some of that with the legislative champion. But for the most part, success comes with a lot of groundwork being laid with partners and building this initial collaborative that Amy Rose White was involved in, et cetera. And I just wanted to also share that we had created a toolkit that Amy Rose White developed or used to develop the collaborative. And so for those of you who are interested in some of this initial convening work and invitations and a slide deck and who should be a backbone partner, we've got 2020 Mom has a toolkit for that. So we're happy to share that with those that are interested. I also wanted to ask you, because I think, Brooke, we've heard the group, the YWCA, mentioned a couple of times, which is such an interesting partner, not on today's session, but in previous conversations. Would you mind just touching on the role that they have played? And I believe it might have been specific to this advocacy work, so perhaps the Advocacy Committee that you mentioned.
Yeah, so the YWCA, I actually messaged her and asked her about the history of how she got involved, because first of all, she couldn't be here, but she has been so important in this work. So the woman is Erin Jemison, and she is the YWCA's policy director. And her, in conjunction with Jessie Mandel from Voices of Utah Children, who's the Voices of Utah Children policy director, really have a lot of deep roots at our state legislature. They are well connected, and their whole purpose is to create policies that will influence for the better the populations they serve. So the YWCA, as Erin got more and more involved, she realized that these women who are experiencing domestic violence or homelessness or all the different populations, that mental health was a common thread throughout all of those. And many of the women that they see there have children, and she realized, this perinatal period is like imperative if we want to really make lasting change for the population she worked with. And so she actually got an invitation from the woman at Intermountain Healthcare and said, hey, you need to come join this group. And she is now the president of the policy group, and she runs and leads us fearlessly, spending many, many hours during the legislative session and outside of it up at Capitol Hill, and being key in finding the right champions within the legislature, understanding their stance and understanding, like, really strategizing on how to do that in a relatively conservative state. So, and as you'll see on the next slide, we actually haven't passed any bills or legislation, but we've been able to do this strategically through concurrent resolutions and governor designations and appropriations, which I think is unique to us here compared to other states.
That's right. Utah is doing some great work without legislation, as you point out, Brooke, which we really are excited to share with our audience. That most of us think about introducing and drafting a bill, which isn't necessarily always the right way to go. We've got to think about all of our options. So this is great. We'll have you walk us through this timeline, and then we'll pause for questions.
Great. This is actually responding to one of the questions in the chat, but so the Utah Maternal Mental Health Collaborative did eventually fold into Postpartum Support International Utah's chapter. So that was back in 2017, and we aligned all of our work with PSI because they have a lot of great infrastructure, and we're doing the things that we wanted to do so we could receive some additional support in that way. So the next thing that happened was once it became PSI Utah, there was the policy group was formed, and that is led again by the policy director of the YWCA. And that was both in part because other people involved couldn't be involved in policy. For example, the Department of Health. We can't be directly involved in legislation. We also have other people at the table like our Utah SAMHSA and other people in government and universities, et cetera. So they are an advocacy group, and they were able to really lead that way. So they published a white paper in November of 2017, basically outlining priorities, what we're doing well here in Utah, what we can work on, and authored it again through that Utah PSI policy group. And it has been kind of the framework for how the group has tackled moving forward with policy and advocacy. For example, one of the things listed on there, and Erin puts like all the things that we wanted to create, or all the gaps at the bottom of every agenda with a little check mark with all the things we've done. So it actually makes us feel really good to see, hey, this is what we kind of like our dream pie in the sky November 2017, and we've actually accomplished a lot of the things on there. So that white paper is published. You can find it on the internet anywhere. It's just tinyurl.com/MMH white paper, maternal mental health white paper. So you can find that. So after that, in March of 2018, during the legislative session here in Utah, that group found two sponsors, a representative, floor sponsor, and a senator, bill sponsor, and published the state concurrent resolution outlining maternal mental health as a statewide priority. So in that Senate concurrent resolution, so SCR 11, they wanted to, they had the legislation say that we are allowed to train providers, we should train providers, we should screen, there should be public awareness, and we're supporting prevention and peer support models. There was no funding attached to that, but it was just kind of a start, some groundwork saying, hey, this is important to legislation, and we're putting this out as a concurrent resolution. Erin's theory is kind of to make sure that during every legislative session, they hear the words maternal mental health, so it's always front of the mind, that they realize this is a priority in the state. So After that, in May of 2018, we asked the governor to designate May as Maternal Mental Health Month, and he did. So we have the official governor's declaration, which again is just one more piece in our arsenal saying this is important to the state. Moving over to March of 2018, that quality improvement group was created, which is the UWINC Maternal Mental Health Committee. And so that is a little bit different from PSI in that it really deals with frontline primary care providers and, again, creating and implementing that statewide universal screening at the provider level. So, and then, sorry, did you have a question? I heard a little pause. No? Okay. And then going down through, and we did another governor's designation this year, February of this year. So then early last year or mid last year, the building block request was put in to create this telemental health program that that Gwen will be presenting on later, and that was through the Department of Health. I'll let her explain a little bit more about that process because I'm not too familiar with that process, but that was the beginning of the pilot of this program, which gave us enough data to be able to support it when asking for the appropriations request earlier this year. So then June of last year, the Department of Health, the Title V program, was able to fund a designated maternal mental health person at the state health department, which is me. So they got this funding and they said, okay, we have enough funding for 1 year. Let's hope that we can get some more later to keep you. But for now, we have this funding to have one person instead of all these many different groups of people who have other full-time jobs as well, kind of working on things. Let's have one person focusing on this at the health department. So that was me. I started June of last year. Then February of this year, again, we have that governor designation, and that was strategic because the legislative session is February through March. So we know that May is Maternal Mental Health Month, but we wanted to piggyback kind of on the appropriation request that we knew was coming up the pipeline. So in March of this year, the group decided to do an appropriations instead of legislation because they didn't need to change the state statute based on what they wanted to do. And the legislative sponsor suggested that they just go straight for funding because that's actually what they needed in order to accomplish what they wanted to do. Our state applied for the HRSA funding and we didn't receive it, and we had all these grand ideas that kind of bubbled up, and we said, hey, we still want to do some of these things. Let's just go straight for the funding. So with the appropriations request, we only had to go to one committee rather than multiple committees in the House and the Senate. Plus, if you do a bill, you have to pass it on the floor, and then legislation still needs to get funded. This way, it was just one committee and one small group of people that we had to present to. And so it was riskier because it was a smaller group of people making the decision, but for us, it ended up working. And it worked because we had, again, this, advocacy genius kind of leading us. And then we had a plan. We had evidence on the pilot for the telemental health program. We had 10 to 15 women coming and telling their story, so moms with lived experience. And then that appropriations request is funding both my position for 3 more years, a referral network and website that will hold all of the information for different places people can go for maternal mental health here in the state. And it also funds the telemental health program that Gwen's going to be presenting on.
Great. We're going to pause to see if there are any other questions on this timeline. But again, just really nice to see, and you fleshed it out for us. Again, the infrastructure that's been in place with many partners over time that you all have been able to bring in to the fold, which is quite impressive. Also, the policy expertise that you were able to tap into, and most of us don't have a paid lobbyist, or none of us really do in this space. So to be able to tap into Erin's work with YWCA, it was just very instrumental it sounded like, and very strategic and smart on your end. So wanted to acknowledge that. Let's just see if there are any other questions that have come in. Great. I also, before we move on to the telehealth component, I just wanted to also acknowledge how smart it has been of you all to introduce resolutions, awareness resolutions, to get maternal mental health in front of your legislature a couple years in a row before you actually had this appropriations ask. So quite impressive. Brooke, I don't think you touched on, I know we've shared it in our marketing materials about the webinar, but can you just remind everyone about the appropriations that were awarded before we move into the chunk of funding that went to and will go to the telehealth program? So there were three. It was a 3-year appropriations, as I recall.
Yeah, so it was a 3-year appropriations for $220,000 each year, and we went through the Social Services Appropriations Committee here within our state. Again, passing bills are not really an option, or they haven't been so far here, but asking for funding and saying, hey, this is something that's happening to your wife, your daughter, your neighbor, based on all the people who came, was really important. So that appropriations request, and we also, from the health department, we had data through our perinatal mortality review committee showing that the top 2 leading causes of death in Utah are accidental drug overdose and suicide. So they're related to mental health. We had our Utah president of ACOG come and testify for us. I mean, we had, like I said, this is like no small group effort. Like every single part of that touch points that you can think of was represented at the appropriations testimony. So, and we had a wonderful representative this year. Representative Jen Daly Provo was a really remarkable champion for the cause and speaking to her peers about this important cause.
That's great. And again, and we invite any of you who are joining us live to ask any questions you have about that process. But congratulations on the success of that appropriations win, almost $1 million, just shy of $1 million over 3 years to build out these programs. Really, really impressive work. So why don't we move on? We heard, just to recap, we heard that the program funds went to bringing Brooke on, or keeping her on as a MMH specialist at the Department of Health. We're going to hear now about the telehealth program work. Let me actually, Brooke, pause for just a moment. Also have you touch on the directory work that the funds will also fund. Did you want to touch on that?
Yeah, I would love to. So we have a list that we've just been keeping in like a Google Doc or an Excel spreadsheet of all the people who are trained in maternal mental health. And that includes, again, all those touch points individuals, including doulas, lactation consultants, physical therapists, not just what we think of traditionally as the primary care provider, but anybody who's been part of our PSI Utah trainings and who has participated in other trainings that we consider maternal mental health. So Karen Kleinman, PSI National, et cetera, 2020 Mom, all those trainings. So we have kind of this database, but there are many states who have the funds to be able to pay for a warm line specialist who can answer calls from moms or doctors' offices and say, okay, here is a referral based on your score and your screening. Let's send you to this place, for example. Since we couldn't do that, we had decided to create this referral network website that is actually going to be pretty spiffy technologically. Spiffy is my scientific term. But it is going to be able to be searchable based on a lot of different requirements. So somebody can say, I want to find somebody that is within 10 miles of my home, who speaks Spanish, who takes Medicaid or Blue Cross, and provides childcare. And it'll pull up all the people who kind of fit under that requirement. And we're hoping that this website will be utilized both by moms and their family members or anybody affected by perinatal mental health, and also doctors' offices, since the quality improvement group will be implementing statewide screening. As you know, many of the providers are hesitant to screen if they don't know where to refer somebody. They feel like they don't want to do it because then what is always the question. So this website that we have will be able to be utilized by them and by many other different groups of people to say, okay, this is where you can go, and this is somebody that we trust and know has been trained in maternal mental health. And that's a very fast overview of it, but there's a lot of different components to it that'll be built out as part of this funding.
Great. Well, we'll be sure to keep an eye out about the directory and make sure all of you on the line have a chance to learn more about that as it unfolds. Brooke, thank you for your part of the presentation. We'll now flip slides here and turn it over to Dr. Latondras to share a little bit more about the telehealth program that these funds will expand. So, Dr. Latondras, I'm going to turn it over to you.
Thank you very much. Actually, if you want to go back to that previous slide, I wanted to talk a little bit about the sort of sequential, events that happened when we were looking at funding and conducting telehealth. So when we, let's see, it was July 2017, we had the Utah legislature in their legislative session, January, February, had determined they wanted to give the Department of Health a good chunk of funds for telehealth. So it wasn't specific to maternal mental health, but for telehealth for the state of Utah. As Brooke had mentioned, we're a largely rural state with most of our population in an urban setting, but they're really working hard to bring more telehealth to those rural outlying. I mean, we have places that takes at least 6 to 7 hours to get into, say, Salt Lake City. So I had been working in working with women with perinatal depression, anxiety. I'm a certified nurse midwife as a clinical background, and I went back and got my PhD and began being involved in research on perinatal mental health as my specialty area. So when I saw this call for the telehealth, I said this is a perfect thing that we can submit this application, because we had already been doing some piloting work with telehealth and having these groups of women who were symptomatic with depression or anxiety. So we took that pilot work and submitted it in 2017, and were awarded, I think it was about $275,000 for a 2-year project, pilot project that was specifically for maternal mental health and developing these groups. So we had a couple of purposes and aims, and a big part of that was really implementing a universal electronic screening for perinatal depression. And we wanted to start off with 3 of our rural health districts. And then once we implemented that universal screening, we would then provide mental health services via a telehealth platform, so primarily, again, group and video conference platform. We spent 2 years doing that and really collected a lot of interesting data. I'm going to have you go to the next slide now. So I just wanted to give you a little bit of background. Part of the ability to get this 2-year grant hinges on the fact that we had that resolution that came about that said, maternal mental health is important in the state of Utah, and we need to do something about it. And so, it was really a lot of synergistic or collaborative work and parallel work, frankly, between our different stakeholders across the state. So this is what we've been doing. In this slide, you can see we've got some arrows pointing to our 3 rural and frontier. The very bottom right-hand side is our furthest, most remote. In fact, it's a frontier, considered frontier because they have so few people in that county. So we worked with their public health clinics, and these are 3 health districts, so Central Health District, Southeast Health District, and San Juan Health District. So those 3 public health district collaborators. And I have to say it was super important to really work with these communities, the people within the communities, the people who live there, are committed to their communities, and have a commitment and passion for improving maternal and child health in their areas. So we worked very closely with them and brought forth the recommendations about universal screening. We helped them to put in place an electronic screening process where we were able to get some funds, use some of these funds, give them electronic tablets like an iPad or and they would have those in these public health clinics. And we set up it's a data management system in REDCap. And so any woman who came into the public health clinic, say for WIC authorization, for immunizations for herself during pregnancy or for her infant during the postpartum period, we were saying these women need to be screened every time that they come in. So they end up coming in maybe twice during pregnancy and a couple times during postpartum, and we would ask them to screen them. And it was on the spot. The scores, the collection it was really set up very well where they get on-the-spot interpretation, so they complete the EPDS, and we also had a set of questions that established their risk factors. So maybe they're not symptomatic now, but they have risk factors for developing depression. And then once they complete that on the spot, the public health nurse could review that with them and identify where they had risk factors or no risk factors, and if they were symptomatic and they were, encouraged or offered resources. For example, we always ask them if they would like us to email them or print out a copy of, say, PSI website, our PSI Utah website, 2020 Mom. We would have our crisis line, some of our mental health professionals that were known on a statewide level, so that moms and the public health nurses working with them in these rural health clinics could immediately have that score interpretation and resources at their fingertips. So anyone who was interested or was referred to us or indicated they would be interested in more like talking with someone or being involved in our groups, we reached out to them. We would have a one-on-one assessment with either a licensed clinical social worker or a psychiatric mental health nurse practitioner. They would then go through what we call a tech check if they wanted to be involved in the video conference platform and join these groups. And we had groups of 4 to 6 women. We used a manualized approach, meaning that we had a manual that's based on, it's called the Uplift program, actually. It was built out of Emory University. And it walks women through with a facilitator cognitive behavioral therapy practices and mindfulness-based practices. So it was an 8-week program. They would meet once a week for an hour by video conference platform in these groups. And so these women were attending from a distance. They could attend from their home or their work. We even had some women who they didn't have internet access and they didn't have a phone or a device, and we would loan them a device. And they would even pull up outside of a public health clinic and could access their internet and sit in their car and attend for an hour. It gave them privacy and access, free access. And so we even had some who did that. We actually had a tablet. I wish I had the photo. I could show it to you. We had a tablet for screening that was traveling on. It was one of their San Juan County RV. They've got this big RV that delivers health services in very remote areas of San Juan County, including out to a place called Montezuma Creek, which is the border of the Navajo Nation and the Utah Navajo Health Services. So they could deal with any urgent mental health issues locally. They could access our services here in the rural setting. We could help, navigate resources for them. We did work, I want to mention that we worked with Utah Telehealth Network and their video conference platform. They offer a really stable video conference platform, which was really important for us to have that. Any questions before we go on to the next slide?
There is one question. I think we're going to hold that question for just a moment because let me tee it up just a little bit. Can you just clarify when you talk about universal screening? It's such a big part, I think, of this program that you've developed. How did you push for universal screening, and do you really just focus on public health clinics? that are state funded, or did you also have an effort with private doctors who may not be in the public health system but reimbursed through insurance companies, for example?
We went where the highest need was, and that's our public health systems. When I show you some of these, I've got some pie charts I want to show you. The demographics were in such high need, and a lot of women filter through the public health clinics in these rural and frontier counties for immunizations and WIC, that we've been targeting the public health clinics. Now, these public health clinics do have, of course, a lot of interaction with their maybe private clinics, outside the public health system. And they have let them know, and they will send women over to the public health specifically to get screened and have access to the resources. So that's been our focus because it was the highest need area in our state.
Great. And one follow-up question, so focusing on public health clinics that are generally, just for people's background, you let us know if this is the case, Dr. Latondras, in Utah, but generally are free clinics that anyone can utilize, even if you're not on a state Medicaid program, for example, even if you have private insurance. Is that? It sounds like that may be the
Correct.
case. So you focused on implementing screening, universal screening in those clinics. So even women, again, with private insurance who may not be screened by their obstetrician could still, if they were not doing well, go to a public clinic. That's really great. And the question that came in had to do with private insurance and the problems with private insurance. And for that person who's asking that question, I think 2020 Mom's actually going to do a separate webinar because there have been quite a few issues or questions, concerns, and opportunities raised around private insurance. And there's some work that's happening there that we can help share some opportunities with a larger audience. So hang tight on that private insurance piece. And thank you, Dr. Latondras, for explaining the universal screening piece and also where you started. Excellent. So we'll go ahead and move on to the next slide.
I do want to say, to follow up on what you just said, is that I think that's been one of our biggest barriers is considering reimbursement for mental health services, not just maternal mental health services, but mental health services, period. And it is one top priority for our policy committee with PSI Utah is to continue to address that issue. We're making a little bit of headway with our Medicaid system, which I won't go into because it's far too complicated. That's for a 4-hour workshop. Anyway, I wanted to just, we collected some very interesting data through our public health clinics doing universal screening, in that in these 3 rural and frontier health districts, we collected some demographic data as well. So, for example, marital status, those who are coming through the public health clinic, remember, this is not reflective of everybody in Utah. These are the public health clinic populations, so we have to keep that in mind as well. About 45% of them are married, 38% are single, 13 are partnered, and some we don't know, they wouldn't answer. Their payer type, you can see Medicaid, huge number, 63% of the women coming in these public health clinics are covered by Medicaid. Private insurance is about 18%, 13% have none, and then other for 6%. We have a racial background. Utah's predominantly Caucasian, but we do have, for example, in San Juan County, about 50% of that county is Native American. And then one of our health districts has maybe a larger Latino population. So you can see that there, 65% white, American Indian, 26%, and then other. And ethnicity, Latino, 12%. If you go to the next slide, this is where we've been able to use this data on the next slide that reports some of our universal screening results. So if you want to go to the next, there we go, perfect. This has been really important for bringing forward to our local mental health authorities and to the Utah Department of Health, as well as to the legislature. So Brooke referred to the appropriations. We went to the Appropriations Committee with some of this data, letting them know, especially in our rural health districts, just what proportion are screening positive and negative, and some of the screening results. And this has been was pretty compelling for them to, they appropriated additional, so I said that you had the 2-year funding that ended in July 1st of 2019, and we went into another subcontract with the Utah Department of Health that was specific to maternal mental health and using telehealth, whereas the previous one was appropriated for just telehealth in general, and we turned it into maternal mental health. So you'll see that in the top left-hand pie chart, we're getting 31% of those women coming in the public health clinics screening positive. And actually showing this data to our community partners has been really interesting for them, because, I mean, we had nurses who were saying, well, I can tell the ones who have depression, so I'm just going to screen them because I know I can tell. And we're like, so it's taken us a lot of effort in visiting face-to-face and doing training in these groups to say, you may think you know which ones, but there's a lot of hidden depression, anxiety, and other mental health because there's such high stigma, and a lot, these women are afraid of losing their kids, and they're looking really well put together. They're dressed well. Their kids are, very well groomed because they're afraid of what might happen if they have depression or anxiety or other mental health issues. So I think we're getting them there more and more as we're demonstrating. The data shows us just what a proportion of women are screening positive and may need their help. The other interesting part is the one on the right, where we have screen positive and they're interested in contact. And the one that worries us a lot, and we've been talking with both the legislature, but also the folks who are in the reimbursement system, so Medicaid, and the local mental health authorities that provide mental health services to Medicaid recipients in these areas. And you can see that nearly half of the women who screen positive decline any contact. So they're in the public health clinic, they're screening positive, the public health nurse is talking to them, and they're like, no, I don't want resources, I don't want to talk to anybody, I will deal with this myself. And Brooke has a very, striking story that she can tell if you'd like, and if we have time in a moment, about some of the events that have unfolded because of this reluctance to accept assistance and help. The last one that I want to point out is the one on the bottom left, and it's the screening results we have low risk. So, nearly half of women are low risk, meaning they don't have any risk factors for developing depression or anxiety or mental health conditions. They don't screen positive for current symptoms. And then because we did add some questions on the EPDS about their risk factors, we wanted to report that as well. So even though 31% are currently symptomatic, another 20% have risk factors, and we know that at least half of those women are going to go on to develop actual symptoms of postpartum anxiety, either later in the pregnancy or postpartum. So these are women we want to also target with preventive services if it's possible. And one of the things we're trying to move towards is actually developing some peer-facilitated groups, and particularly for prevention care for these women. I think that's about all that I wanted to say, except that, at least for these 3 rural communities, we're getting ready to present to all of the public health nurse directors for all, I think we have 13 health districts or 12. Yeah. We're getting ready to present to the entire group of directors of nursing for these public health districts to let them know what we've been doing, provide this data to them, and invite them to join us in the universal screening. So becoming more broad across the state with, implementing universal screening and helping them to access resources for their rural populations. I just have to say that I think 26 out of 29 of our Utah counties are designated maternal mental health profession shortage areas. So we've got a huge gap in our state for having mental health services, and especially, even more so, maternal specific, maternal mental health specific. What we're ending up with is that we need more studies to evaluate the effectiveness of this approach to really prevent depression and reduce depression in the perinatal and postpartum, during pregnancy and postpartum, and to really also study what are the barriers to access. So why is it that nearly half of the women who screen positive refuse any kind of support, resources, or help, and how can we reduce those barriers?
And just
Great.
one more thing to add to that. Oh, sorry, this is Brooke, but our state PRAMS data also backs this up, that half the people who screen do not follow up and access resources. So that's for both anxiety and depression that we monitor here within the state. So that is something that we're trying to overcome through, again, this policy legislation, having women share their stories and saying that this is important to us here within the state.
Great. We really appreciate it. Again, I want to invite our listeners to send in questions through the chat box. I have a couple in the meantime. First, just want to acknowledge all the amazing work that you've been doing. It's incredible, and I think Utah has perhaps been, dare I say, kind of flying under the radar in terms of this amazing work that you're now sharing with us. So I suspect that you're going to be getting quite a few calls and really be being lifted up in a big way as a state that's tackling maternal mental health quite successfully. So again, congratulations, and we know it's not easy work, so thank you for all you're doing. I wanted to share two things. One is that we have really been interested in peer support services as an adjunct to shortage areas, which you've touched on, Dr. Latondras. So many states have severe shortage areas of maternal mental health or mental health providers generally, and then of course we know and we say there are severe shortages of maternal mental health experts on top of those already underserved areas. So to acknowledge again that you're interested in peer support services, I think is really important, and also tie it to those barriers, right? We know that providers are mandatory reporters, and that women really do have a fear of their children being taken away, which you've hit on, and that providing these peer support providers to adjunct, again, the shortage that we have in areas, but also to be a bridge, because these peer supporters aren't mandatory reporters, is, I think, quite impressive and important to point out. The other thing I'll add before I turn it back to you for comments is that we know that, like, one big barrier we have discovered, and I think all of us really have in this space, is that lack of understanding of the difference between psychosis and intrusive thoughts, which generally sit on OCD, but don't have to sit on OCD, right? It's a symptom more than a diagnosis. That is the real barrier, right? That providers are not trained in that distinction, and until we can get that distinction embedded in medical school curriculum through ongoing education, through maintenance of certification, et cetera, that we're going to continue to have the problem that not all providers are going to understand this really critical nuance, and women will be afraid to speak up.
Yeah, I think that's a really important piece. Our Brooke made reference to the Utah Women and Newborn Quality Collaborative, which their emphasis until they had 4 emphasis areas up until about a year and a half ago, which were like preterm birth prevention, postpartum hemorrhage prevention, that sort of thing. And because of this, the resolution that was forwarded through the Utah state, we brought that to that group and made a proposal for a maternal mental health committee, in which they approved, and we've been working with that. So that maternal mental health committee is part of the Utah Women and Newborn Quality Collaborative. Has been working very hard and diligently to put together a training packet, a set of recommendations, of course, based on evidence-based recommendations, an algorithm that worked for the state of Utah. And a big piece of that was knowing that, for example, if a lot of people did not want to screen because they were afraid. If you screen, then you got to know what to do with the results of the screen. And they didn't have the resources to refer to, or they would tell women maybe inappropriate or information like, you can't take medication, so don't even think about it, just buck up until, this will all pass, kind of thing. We've all heard those kinds of stories. So a big piece of what we're doing is putting together a training that will be work well for busy clinics, that doesn't take much time, that gives them puts right into their hand a nice set of resources, a web link that they can go to. I think Brooke may have mentioned this, that if you're in a clinic and you're screening, you have somebody positive, you can go to this website and click on an interactive map of Utah and find out exactly what resources are available in your area and how to get someone immediate help. So we want to make it really easy for them to screen and to know what to do and to access resources for the women they see. We make it easy and smooth, then they're much more likely to adopt it.
Great. We appreciate that insight. We do have one final question that has come in, and then we'll wrap up today's webinar. It's a great question that, again, comes from Abigail from Los Angeles. Thanks, Abigail, for another question. She's asking about the demographics. So on that right part of our screen here, those that screen positive but don't initiate follow-up, what are the demographics of that population? I think we're all probably hypothesizing that those are lower income women that are more at risk, perhaps, of their children being taken away. Is that an accurate?
That's a really good question. That's a really good question. I don't have the breakdown on that, but I think it is an assumption to think that it's our lowest income people. I would be surprised if it breaks out that way, to tell you the truth. The stigma goes across all socioeconomic groups in these areas. Doesn't matter.
Yeah, great point. Is not everyone feels comfortable speaking up regardless of outside risks of children being taken away, maybe being higher. So excellent. Thank you, Abigail, for that question, and also your response, Dr. Latondras. Any closing words from the two of you before we wrap up today's webinar?
This is Brooke. I just wanted to, again, attribute a lot of the work that's happened here in Utah to long before I ever came, so many different people. If you're thinking about implementing this in your state, finding those maternal touch points like a champion in each of those places, in a university system, in your healthcare system, in your health departments, and also other government agencies, advocacy groups, having them all come together and recognize that maternal mental health touches all of their lives and all of their communities and populations, and really selling that to them and that they can understand that, I think, is what's going to be key for states who maybe can't pass, again, bills, or maybe states who do pass bills but are trying to figure out, okay, what's the next step? Like, having every single one of those groups come together has been what has made everything so successful here. So that's just my closing point. If that's the only thing you remember, that's what I want to leave you with. So,
and the only thing I want to add to that is, and I don't think we've mentioned it really in this webinar, is just how important the voices are of women who with lived experiences. So, for example, we went to the Appropriations with the Utah legislature. We had several women who showed up and were brave enough to come up and tell their stories, and then people were in tears, including some of our legislators. So, I personally have run a number of focus groups with these women who have either, before or after they're involved in any of these programs, and their stories are very compelling, and it's really very important to get their input about what they need, the experiences they've had, the barriers they've encountered, what they think should happen. It's really been informative and helpful, and I think we need to make sure we don't lose those voices. We pay special attention to those voices of these women,
including Heather Dopp, who nominated us for this award. So thank you to her, and thank you to 2020 Mom and the sponsors for the Innovation Award. We're so happy to be able to share Utah's story on a national platform.
Great. Thank you again to both of you, and congratulations. I personally am really impressed with all the work that's happening in Utah. I want to make sure that we continue to lift it up in a big way as a best practice. So thanks again I see a few thank yous coming in through the chat box. And we really appreciate everyone attending today, and those of you listening to the recording. And thanks again to the Zoma Foundation, who has funded this program. And we'll be in touch all, and the recording will be sent out shortly. Thanks, everybody, and thank you again for joining us, Brooke and Dr. Latondra.
Thank you very much.
Bye.
Take care. Bye-bye.